movement disorder in which the movement is high and like you're doing excessive movements, right? So movement disorders are simply classified into hyper and hyper movement disorders, depending upon what sort of problem is. When we talk about movement disorders, we talk about the power and we talk about the coordination. The power comes from the motor state in the brain, which is the motor area in the brain, and the coordination comes from the basal ganglia. So the basic problem movement disorder is within the basal ganglia, and that's where the problem comes in. When they are involved, they tend to they lead to problems that are called as movement disorders, right? So, in order to make things very easy, we divide into two major categories. One is when the movement is reduced, decreased, so these like hypomovement disorders, and when the movement is increased and then making more movement, are going hypomovement disorders. So let's see what could be the possibilities of having high and low disorders. Here we have examples of hypomovement disorders like dystonia or Parkinson's disease. So we'll be talking about Parkinson's disease in the next lecture, but as you can see that Parkinson's and dystonia are indicative of low movement. So here the patient is slow, they cannot move, they are rigid, they do not have flexibility, so they are labeled as hypotonic disorders, right? Hypomovement disorders. And the example of hypomovement disorder are the tremors. When there's tremors, you can see tremors, and this is where you see the movement will increase. So they'll be in hypomovement disorders. You may have dystonic tremors, that is, you have tightness in the stomach, still have tremors. You may have chorea, the dancing movements, right? And you have hemivalence movements, again, sort of chorea or sort of dystonia, which is in the half the body. So all those movements who are like high or more in speed or more active than the usual, they will be termed as hypermovement disorders. And here's a second example that as you can see. So regarding dystonia and regarding Parkinson's disease, we'll be talking about Parkinson's disease in the next lecture tomorrow. But today we are addressing the dystonia and hypermovement disorders. Now let's talk about hypermovement disorders. This is slide to tell you that what are we looking today for? What are the aim and objectives that we'll be handling today? And these are the questions that we come to conclusion at the end of a class is, what is the origin of the movement disorder? What brain structures get involved when you have movement disorders? Question 2 is, what is the source or what is the cause of movement disorder? How would you diagnose them and how would you treat them? But before you go to these, you need to understand that we need to see which type of movement this is. Anybody who comes to a clinic will have some form of movement disorder, and from there on, you need to take on. But let's first we need to identify what sort of disorder this is. So we talked about hyper and hyper, and here we go for hyper disorders. The first disorder in hyper is tremors, and I'm sure all of us are very well familiar with tremors, right? And why so? Because whenever you're in stress, when you're in depression, all of us feel tremors, right? And these are called as physiological tremors, right? So this is a normal tremor, and you might have noticed that you're getting exams or facing a difficult situation, your hands might tremble, your legs might tremble, your voice might tremble. So that is what is a normal tremor is. But tremors are classically in three main categories, right? One is called the resting tremors, another called intention tremors, and third called cerebral tremors. What are the resting tremors? If you have tremors while somebody is resting, that means somebody is not moving, you get that is called as resting tremors. And how would you know? Let's say, for example, somebody is sitting in a chair and is trembling. Would you call this as resting tremor? Answer is no. He is not in the rest, but he is in a posture. He's adapting a posture. He's sitting up. Compared to somebody who's lying down, totally on the gravity, right? Then that person is in the resting phase. So the resting tremors are when seen when things completely in the rest, and these are called resting tremors. And the very orthogonal or the very prototype tremors is seen. This tremor is seen in Parkinson's disease. Compared to this, there are intentional tremors, or they are also called as postural tremors. Okay, and these postural tremors can really make up a posture. Right, for example, you're sitting, you're writing, you're holding your hand in front of you, right, like this, or doing something activity, you're holding your neck. This is called posture, right? So tremors that happen in the posture are called intentional tremors, right? And the problem of that is essential tremors or physiological tremors. We talk about physiological tremors that can happen to all of us. Compared to this, there are essential tremors, and they have excessive tremors which are beyond the physiological limit. So they keep on trembling on every time they want to do something. So they want to write, they have trembling, they want to put they want to do any thin work, they start trembling. They're lifting heavy weights, they start trembling up, right? Uh, they're standing, their legs start trembling up, right? They may have neck wounds like this, and very frequently, if you remember, whenever we used to do plays in the childhood, when we try to resemble somebody elderly, we try to break our voice. Like, so what is this? This is basically the voice tremors. So this is and then you start trembling and trembling because you try to pretend that this is an elderly person. Why? Because these tremors are more common in elderly. So it becomes a common form when you try to pretend that somebody is old in age and is trembling. But these basically all elderly do not tremble, and this is because they have essential tremors. So essential tremors are tremors which are like a disorder that will affect your life, and they can be seen in different parts of the body. They will see in the hand, they will see in the tongue, they will see in the head, in your legs, depending upon which area is more involved. And these essential tremors are normally seen in elderly, like around 60 or 70, but they may be genetic in origin, and those who have a genetic in origin will have these tremors at younger age. If somebody has essential tremors, let's say at 70 or 60, his kids might have them at 30 or 40 because it's a genetic disorder. Since there may be sporadic, that means that they do not have a genetic disorder to come on, but they can come on their own. So these are the common tremors, and how do you demonstrate them? You ask the person to raise their arms in the air and stand like this, or make a gesture like this, or hold a cup or a glass to the human trembling, or make up a spiral on the paper, a piece of paper or blackboard, and you come to know that the tremor they cannot sign, they have tremors. So these are called essential tremors. Compared to this, then there are cerebellar tremors. Now, what is it between cerebellar and tension tremors? Both will happen when the movement will come. Compared to the resting tremor, will happen only when there is rest. And when the patient starts moving, the tremor will disappear. The resting tremors will disappear when the patient is making any intentional movement. Compared to this, intentional tremor will come when you are making a posture. Cerebellar tremors are those which come on the movement, but at the end of the movement. Very famously, the finger nose test. So you have a person ask a person to make a finger to touch the tip of the finger and your nose, and you can see that I'm not making tremors. So when somebody is cerebral tremor, you're not going to fixate on the at the end of the movement. They will start moving like this. So that they will come here and then start shaking like this. And these are called as intention, these are called as cerebellar tremors, right? So cerebellar tremors come from cerebellum. So they are very specific form of presentation. Commonly seen in function on finger nose test or heat in test, and these are called as cerebellar tremors. So when talking about tremors, they classify three types of prototype three tremors: resting tremors, intention tremors, and cerebellar tremors. So whenever people present to you with this, you need to look out at what sort of tremor somebody is suffering from, and then you can look up a diagnosis and then go ahead. Then comes your dystonia. So what is the term dystonia mean? The term dystonia means tightness, right? Stiffness, right? So you have stiffness of the muscles. Your muscle is stiff. Before we go to dystonia, right, because we have more hyperactive motor disorders like tremors, we talk first about chorea for that you can understand. What is chorea and what is hemiballismus and epitosis, right? So chorea is basically fidgety or quasi-purpose movements. What do you mean fidgety? According to that means that when we are sitting still, we are sitting still, and we can sit still or stand still for a longer time as long as we want. But in Korea, there is repeatedly involuntary movement, so they cannot sit in one place. They keep on moving, and they try to pretend that they are doing something active, and that's what is called as quasi-purpose. Quasi-purpose means that is like there's some reason or some purpose. For example, so you can see I'm trying to move all the time, and these movements look like that I'm doing on purpose, but I'm trying to hide the movements that are there, which are not there, but they come involuntary and trying to pretend that I'm doing them on purpose. So they keep on moving and they while walking, they might fall down to one side, they might lurch to one side, but this is called as chorea. The chorea is quasi-purpose involuntary movements that they cannot control the movements, right? And these are called chorea. So chorea can happen in many diseases. Okay, we'll talk about it later. But this is what chorea is called. Compared to this, hemorrhages and acidosis are also basically forms of chorea, except that they have a very specific picture. Acidosis is when you have wiggling movements of the hand, people have something like doing break dance, right? Called acidosis. And hemorrhages is when you have violent one side movement on the one half of the body. But hemi means half, and ballistic means ballistic. They are very fast rapid movements, but it's hemiballism. So chorea, acidosis, and ballistic are categorically one disease, except that they can different is because of the classical presentation. Then, since the stonic tremors and dystonia have both things together, that is dystonia and that is stonic tremors, we need to understand what is dystonia. So, dystonia is basically a continuous spasm of one sort of muscles, like flexors or extensors. There may be a combination, both flexors and extensors, depending upon, but there is persistent contraction. And that leads to an abnormal movement or abnormal posture of that part of the body. And this is sonic movements again can be focalized towards could be just sorry, could be just focal. That means they are only localized to one area of the body, like the list is starting. And you have closure of eyes, they cannot open eyes just like this. They keep on closing their eyes. They cannot keep their eyes open. In one area, they may have a hanging spasm that is like spasm of one half of the face. They may be generalized, they may be segmented like the whole neck. So like in the stone, they will turn over side, right? And they may have like this, intercolaris, depending on period and okay, the different positions depending on the limbs or the body, and they may be generalized over the whole body. And so there is this persistent movement, right? The dystonic movement is turning of neck towards one side or one part of the body like this, because they cannot open their fingers because that is their dystonic movement. Dystonic tremors is when you have both amount of flexor and extensor muscles. So you have this tremor type activity in here, there is flexion and extension, and you can see that it is moving. Where this is called dystonic tremors. But this is not a tremor, this is because of dystonia. So that's why dystonic tremor becomes into a combination of two, that is slow and high. So these are prototype main basic types of movement disorders, of hypermovement disorders that we talk about. And so this is the first thing is identification of what sort of activity is going on. Now we come back to three main categories, main questions. And what is the origin of movement disorder? Where the problem comes from? What is the brain area whose involvement causing these problems? And the answer is basal ganglia and your substantia nigra, right? So these are the areas where the movement disorders originate, and this is where they cause a problem. Depending on area of involvement, they may have different type of origins. For example, Korea comes from like caudate nucleus, right? The Huntington's chorea is notorious for involvement of the caudate nucleus. There's atrophy of caudate nucleus that causes involvement of Huntington's chorea. And similarly, the movement disorders can come from the ganglia, include gluteus, they get and the different nucleus, right? But we cannot sort of localize them to one unit. We're saying that if अगर gluten not होगा तो ये होगा, thalamus होगा तो ये होगा. We cannot say this because we all know that when there is DNA involved, it causes increase to one of the immune disorders. What are the causes of immune disorders? Well, anything that causes involvement of basal ganglia, let it be stroke, let it be a tumor, let it be a hemorrhage, or let it be a degenerative disorder. It can cause immune disorders. The most common disorders basically are degenerative. That is, there is no reason for the treatment not to work, right? And what is the most common disorder? The answer is tremors. That is the most common immune disorder. Then how to diagnose a immune disorder? When the diagnosis comes from clinical examination and history, depends upon what areas involved, what sort of immune what sort of immune you can see, and then your clinical diagnosis will make up a diagnosis. You can confirm the diagnosis by doing certain tests like MRI brain, and will give you there is some pathological structure or not. So categorically, MRI will tell you the difference between degenerative disorders and non-degenerative, like a structural versus non-structural pathology. If you're structural pathology, then you know that there's a problem because of structural pathology like stroke or tumor, right? And there's something structural problem. Or when you have degenerative disorder, MRI normal or may have atrophy of certain structures, leading to the diagnosis of the movement disorder. Then comes how you treat it. Well, that depends upon which disorder you're talking about. If you have Parkinson, you're different. If you have dystonia, the best treatment is injection Botox. So Botox is an injection that is recently delivered, introduced, and it is basically coming from Botox, which is Botox, which is botulinum toxin. You know, Botox is very, very recent. It can kill in a very small amount. So they further diluted it out and get a Botox injection, and that will give them in this one year. In tremors, depends upon what sort of tremors they are. If they are essential tremors, if they are resting tremors, the resting tremors is feature of Parkinson's. While the essential tremor is another entity. We have different treatment like beta blockers or like we have topiramate. We can also give uh, mysoline, a drug called mysoline. We can also treat drugs and tremors. And cerebral tremors depend upon what is the cause of cerebellum and then different medication that we give for that treatment. So categorically to make things very easy, again we go back. Movement disorders are basically abnormal movements, involuntary movements which are not under control. Again, they can be high or low depending upon how they present. The type of high or low is Parkinson's disorder and your dystonia. And happy exams are tremors and chorea, breathlessness, and choreotyphosis, right? Now, after saying that we can, and then so then we once we identify, we do investigation to find out the cause and then treat the problem. By and large, most of the mood disorders are clinically diagnosed. Scans are only done to confirm structural pathology versus non-structural pathology. And there is no specific test or a test to identify if this person has essential tremor, this has Parkinson's. There's no specific test to pathologically identify which sort of mood disorder you're talking about or what is the cause in this patient. So
हेलो
this
सर।
gives you a bro. जी
सर थोड़ी सी वॉइस आपकी क्लियर नहीं है, अगर माइक करीब से
क्लियर
लगा।
नहीं है।
जी सर।
माइक कहाँ पर होगा? माइक क्लियर है? कैन यू अब आवाज क्लियर है?
यस सर, इस तरह तेज आ रही है।
इससे
क्लियर आ
बेहतर है?
रही है।
ओके,
यस सर।
ठीक है। अच्छा जी, तो इस वक्त हमें आपको एक कॉन्सेप्ट क्रिएट करना है कि मूवमेंट डिसऑर्डर्स को आप आइडेंटिफाई कर लें, उनके आपको नाम आने चाहिए, यू शुड नो कहाँ से उठते हैं और आप कैसे डायग्नोज करेंगे। किसी भी डिजीज को डायग्नोज करने के लिए आपको साइन सिम्टम्स आने चाहिए, पैथोफिजियोलॉजी आनी चाहिए, डायग्नोस्टिक टूल आनी चाहिए और ट्रीटमेंट आनी चाहिए। तो लेकिन मूवमेंट डिसऑर्डर कैटेगोरिकली सबसे इम्पोर्टेंट बात ये कि किस तरह की मूवमेंट डिसऑर्डर है, ठीक है। एंड देन सबके लिए आप तकरीबन एमआरआई कराते हैं, ठीक है। उसमें आप गैंग्लिया को देख लेंगे मेनली टू डिफरेंशिएट स्ट्रक्चर वर्सेस नॉन स्ट्रक्चरल पैथोलॉजी एंड देन यू ट्रीट अकॉर्डिंगली डिपेंडिंग अपॉन कि कौन सा एरिया इन्वॉल्व है और कौन सी मूवमेंट डिसऑर्डर है। अब हम बात करते हैं विल्सन डिजीज की। विल्सन डिजीज किस चीज़ का नाम है? विल्सन डिजीज अगेन एक बीमारी का नाम है जो कि हमारे बेसिक गैंग्लिया को इन्वॉल्व करती है, ठीक है। बेसिकली इट हैज टू डू विद योर कॉपर, ठीक है। तो बेसिक गैंग्लिया हमने कहा था कि स्ट्रक्चर नॉन स्ट्रक्चर, इसके अंदर नॉन स्ट्रक्चरल प्रॉब्लम ये है कि द कॉपर गेट्स एक्यूमुलेटेड इन योर बेसिल गैंग्लिया एंड दैट्स व्हेन द प्रॉब्लम कम्स कि ये जो है इट हैज एबनॉर्मल मूवमेंट्स, ठीक है, एबनॉर्मल पोस्चरिंग एंड दैट्स व्हाई इट कम्स इन न्यूरोलॉजी। अगरचे विल्सन डिजीज आल्सो अफेक्ट्स योर लिवर and your brain, ठीक है। Categorically in the younger age group it was the liver and elderly will involve people, and when we say young that means childhood के अंदर liver और teenage में या adolescent के अंदर involve your brain। So Wilson disease में two categories main organs involved, one is brain, other is liver। There may be other organs involved like your eye और other organs also involved, लेकिन categorically जो आप याद रखना है brain, liver और eye, ये तीन organs आपने याद रखने हैं। Again, why does it happen? It is basically inherited disorder, it is autosomal recessive disorder, and it is caused because of mutation of ATP7B gene, right? And what does it lead to? It leads to abnormal transport of the copper, and that's it cannot be excreted from the body, and that leads to accumulation of the copper in different areas of the brain, ठीक है, and that will cause a problem। अगर बच्चों में अगर तो it may come with hepatitis, ठीक है, because they were chronic liver disease, इसके अंदर जो ये विल्सन डिजीज एंड in case of adults, how will come in adults? Adults पर डिपेंड करेगा कि ये इन्वायरमेंट किस एरिया का है। मेनली जो बहुत ऑब्वियस होता है वो आपके बेसिक गैंग्लिया के इन्वायरमेंट से होता है और उसके अंदर क्लासिकल आपके ट्रेमर्स हो सकते हैं, हिस्टोनिक मूव्स हो सकते हैं, ठीक है ना। मेनली ट्रेमर्स डिस्टोनिया इस शक्ल में जाहिर होते हैं। सो पीपल में हैव ट्रेमर्स, ठीक है, दे हैव डिस्टोनिक ट्रेमर्स, एब्नॉर्मल पोस्चरिंग, ठीक है, मेंटल रिटार्डेशन होती है, mentally they are not as sharp as they were, and they progressively become worse and worse. Okay, and only affect your limbs and your face. Eye may it leaves a pathognomic sign which is called as Kessler fissuring, which is deposit of your copper in your cornea, and it forms a ring around the external side of the cornea. We call it Kessler fissuring. Okay, and you can see this through slit lamp. A very important here in MCQ in your exams and during your viva will be if you want to think, if you think about Wilson disease, what organ you look into. The clinical thing you look into is will I get a slit lamp examination, and they can tell you if you have a Kessler pressure ring or not. If you have Kessler pressure ring, that means you have Wilson's disease. Then it may affect your bones as well, and may also affect and may also affect your kidneys, leading to renal damages. Liver it may cause again hepatitis, and we talked about cirrhosis, you have hepatomegaly or jaundice. But this is only mainly in your young children. But again, so Wilson disease की जो major cutout presentation again movement disorder के साथ है. अगर एक young आदमी आ रहा है movement disorder में आ रहा है, you must put out Wilson disease. For you so that you go for eye examination and you will do for a blood test, right? ठीक है. अब ब्लड टेस्ट में क्या करेंगे? ब्लड टेस्ट के अंदर हम दो तीन टेस्ट करते हैं इसमें. एक एक 24 आवर यूरिन कलेक्शन टेस्ट है कि हम 24 आवर्स में यूरिन कलेक्ट करते हैं इसमें कॉपर कितना आ रहा है. देन यू आल्सो डू योर serum ceruloplasmin. Serum ceruloplasmin is the protein that carries your copper. उसको चेक कर लेते हैं. Then thirdly do serum copper levels. Copper level कितना है. And how do you diagnose? Well, you diagnose through these tests. You may have an MRI done. MRI will show you abnormality of the basal ganglia. So in the clinical setting, MRI, the blood test, serum ceruloplasmin, and 24 your copper and serum copper. These four tests will help you make a diagnosis of Wilson's disease. And then how you treat, the treatment is in chelating, in bringing your copper out of your body. So you want to make a proper excretion, but we have for that you have two type of medications. One is penicillamines, which will cause the copper to dislodge from the stores. When they're stored in the basal ganglia, in your liver, in your kidneys, you want to discharge them. So penicillin will help you in chelating the bring the medication out of the cells, and zinc will try to keep the levels down. And sorry, the zinc will keep you help you the help from absorbing the copper from the gut. So when you have less absorption in the gut, you can use the current copper, and this way you can go back to normal. So first, treatment will be penicillamines induction, and then once this is controlled, then you go for zinc sulfate throughout your life to keep your copper levels low. तो वैसे में पहचानने की बात नहीं, सिर्फ ये बात है कि इसमें जो क्लिनिकल प्रेजेंटेशन है वो उसी तरह मूवमेंट डिसऑर्डर्स की होती है जो हमने बात की हमने. उसमें पार्किंसोनिक फीचर हो सकते हैं, स्टोनिया हो सकता है, ट्रेमर्स हो सकते हैं, एक्सेप्ट इट इज हैपनिंग इन द यंग एज. अगर डिफरेंट मोड में साथ में अगर सोचेंगे, टियरिंग सोचेंगे, ठीक है. मोस्टली यंग लोग अगर मूवमेंट डिसऑर्डर आ रहे हैं तो वी विल थिंक अबाउट विल्सन्स until proven otherwise. इसके अलावा जो है कि हम डिफरेंट डिसऑर्डर की बाकी भी डिसऑर्डर है, उनकी जेनेटिक डिसऑर्डर है जो कि बड़ी एज में आते हैं. शॉर्ट ऑफ एसेंशियल ट्रेमर जिसको कि पहले भी आ सकते हैं. तो दिस इज sort of wrap up or let's say